This is Blood and Cancer, the official podcast of MDedge Hematology-Oncology, where we bring you interviews with clinical leaders to impact your daily practice and the human side of hematology-oncology care straight to your earbuds, smart speaker, or your commute. I'm the voice of MDedge Podcasts, Nick Andrews. Welcome to episode 37 of Blood and Cancer. I'm the voice of MDedge Podcast, Nick Andrews, and I'm joined as we record this by the editor-in-chief of MDedge Hematology-Oncology, Dr. David Henry. And Dr. Henry, something interesting this week. We start part 1 of 3 with our fellows and trainees and conversations, difficult conversations with patients is the theme. It's going to be very exciting.
Well, it's going to be very interesting. I know all 3. They're all very talented up-and-comers. Our future is secure in oncology with people like this. Ilana is a senior fellow at Stanford and has a very classy and novel podcast she does for us each week on blood and cancer after the interview we do with some thought leader. And she's going to be joined by 2 of our residents at Pennsylvania Hospital in Philadelphia, Emily Bryer, who's a senior resident interviewing for fellowship this year, and Ronak Mistry, who's also a senior fellow, but going to be an assistant coming up chief resident next year, doing an extra year. So he'll be 1 year behind her. So they all are in oncology, passionate about it, working in it, publishing in it. So Ilana had the idea to talk to them about, from her perspective, in the 3rd year of fellowship, to Emily and Ronak, who are senior residents, and what it's like to do what. And so tonight, the difficult patient discussion. And I just had one today. We finished the clinic with a very sad, out of the blue pancreas cancer metastatic to liver, family there, patient there, talking about it. And actually this patient said, "Don't tell me my stage, I don't want to know." I had 2 students with me. So we walked out of the room and I said, "What if she had said, 'How long do I have to live?' What would you say?" And they just kind of froze. And one said, "Well, you never remove all hope." And I said, A+, better the class. You'll hear in this discussion, Ilana and Emily and Ronak, that's the sort of thing that you have to be careful to never remove all hope, no matter how significant the pancreas cancer in this case seems to be.
Yeah, absolutely. So first, it's worth noting to all of the blood and cancer fans out there that Drs. Mistry and Bryer have been the people behind our show notes all this time. So this is their first time out in the public, which is very exciting. But the other thing I wanted to mention was Dr. Yurkiewicz is obviously the more seasoned of the 3 of them. But from your perspective, from someone who's been doing it a little longer, I would guess.
A little longer.
What these conversations with patients, I imagine that on one hand, they get routine, but on the other hand, they really don't at all.
Boy, they really don't at all. And you, as soon as this comes up, and I knew this was going to be one of those, you must, there's certain things you have to do, even body language. You just have to sit down, make it clear to the patient you're not rushed, that you have adequate time to lay out what's going on, let them ask questions. You hope, and is the case today, they bring other people with them. And I get a lot of locking up the eyes. So I watch the patient's eyes, because as you start to get really heavier and heavier, the eyes go off and she's thinking and not listening. And so I sort of slow down, maybe repeat myself, wait for the eyes to come back.
Yeah, that's a really good tip. You never think about that. I've been in some situations and read books or watch movies about people who have maybe lost a parent at a young age, and that's a really good observation that I never really would have thought about. What a great insight there. So this is part 1 of 3. We're going to do 3 parts of difficult conversations for trainees, for anybody considering a hematology-oncology fellowship, or maybe you're a med student, or maybe you just want to be reinvigorated with the difficulties and put some juice back in your veins in terms of how to have these kind of conversations with patients. So we're going to be doing this for the next 3 weeks, and so part 1 is coming up a little later. But I want to transition to this week in hematology-oncology from MDedge Hemonc, and we have ourselves an FDA approval from the Keynote trials, and this time it is for advanced endometrial carcinoma. It's Keynote 146, and the Keynote trials have been doing really well. Obviously, pembrolizumab, a very famous drug, and in this time it's a combination with lenvatinib.
So this is the blessing and a curse of our specialty. So I'm in the clinic in the hospital on Friday, and I walk by one of our GYN oncologists who stops me and says, "Have you heard?" And I said, "Heard what?" She's a new approval. And I said, "No, I can't keep up. They're almost every week." And so she told me about this. It just came out, as you said. So pembrolizumab, our PD-L1 ligand locker upper, so that the tumor can't push the off switch of the body's immune system, wakes it up,
Mm-hmm.
and it finds the tumor, which is non-self, in combination with lenvatinib, which is a VEGF, vascular endothelial growth factor inhibitor, similar to bevacizumab, which most of our audience will have heard about long ago. This is another one. So in combination, they really seem to work well in endometrial cancer. I think this article highlights a 38% response rate,
Yes.
and that's really impressive.
Yeah, let's run down the data real quick. 108 patients with metastatic endothelial carcinoma, 94 were not microsatellite instability high or mismatch repair deficient. 38% response, 10 complete responses, 26 partial responses. Looking at common adverse events, all of the usual suspects: fatigue, hypertension, musculoskeletal pain, diarrhea, decreased appetite, hypothyroidism, nausea, vomiting, decreased weight, abdominal pain, headache, et cetera, but just things to watch out for when you use these kind of medications.
So true. They're not chemotherapy. They're very different, and they come with their own special set of side effects, which we watch for.
Absolutely. So that's This Week in Hematology Oncology. You can stay up to date by clicking the link in the podcast notes or typing in mdedge.com/hematology-oncology. Other headlines from around Hemonc: combo could be the new standard for transplant-eligible newly diagnosed myeloma patients. Closure of women's health clinics may negatively impact cervical cancer outcomes, and many institutions exceed recommended radiation doses during lung cancer screening. You can find that and more at mdedge.com/hematology-oncology. So without further ado, this very exciting, I think fall, everybody's back in class, and there's that back to school mentality. It's a good time to check in with some trainees. So I think it's time to kick it over to Dr. Ilana Yurkiewicz.
Get your pencil and papers ready. Back to school. Here they come.
Here we go.
I'm Dr. Ilana Yurkiewicz, and I'm delighted to host this week's episode of Blood and Cancer on preparing for fellowship, with the particular topic that we're going to focus on today being difficult conversations that come up frequently during fellowship. I am delighted to be joined here today with two residents from the University of Pennsylvania, Dr. Emily Bryer and Dr. Ronak Mistry. Welcome to the show.
Thank you.
So, like I said, our goal today is to address some common hard situations that come up for new fellows. So the way we're going to run this interview is I'm going to run a few cases by you guys, and I'm hoping we can have an open discussion about what makes these situations challenging and what are some ways to handle these situations. And all of these cases that I'm going to bring up are actually based on real experiences that I've had during my fellowship. So the first case I want to talk about, the theme is, how long do I have to live? And here's the case. So a 65-year-old woman with no significant past medical history is referred to your clinic for a new diagnosis of lung cancer. She presented with a cough, had a chest x-ray and a CT showing a lung mass. She underwent a bronchoscopy with biopsies showing non-small cell lung cancer, and a PET scan unfortunately showed that she had diffuse metastases in her lymph nodes and liver. She has no targetable mutations. You discuss first-line options for immunotherapy and chemotherapy. You do tell her that her cancer is metastatic, so we are aiming for shrinkage or stabilization of disease. All of a sudden, she breaks down and shows you a picture on her phone of her 1-year-old grandchild. She asks you, "Doc, how long do I have to live?" So before we kind of get into the meat of how to deal with this conversation, I wanted to ask you guys, have you ever experienced anything like this during your residency?
I definitely have. And oftentimes it is, it's when you're meeting these patients for the first time coming to the hospital, they're seeing a new resident, a new face, and they're just scared. And I think, Emily, maybe your experience is a little bit different, but in my experience, it's been that they're looking for hope because they have had this difficult conversation with their oncologist already, and they're hopeful that having someone else in the picture now, someone fresh, someone new, might be able to tell them something that they hadn't heard before. So it's almost like a unique situation to what you're describing, I think, but nonetheless something that I know I've experienced for sure.
And I definitely have had similar experiences to what you described, Ronak. Even in patients who are hospitalized when their cancer is first diagnosed, and they ask, the resident or, something that we may not necessarily know without speaking with the attending first, but they're difficult situations for sure.
Yeah, and I know it's really hard, and seeing this a lot of times, sometimes it can make it easier, but often it's still difficult every single time. And so I think what you guys are saying, as specifically, Ronak, what you said about the patient looking for hope, is really astute. So I think the first thing I wanted to just say about this case is when this patient breaks down and, shows you a picture of her grandchild and she asks you this question, she's asking an emotional question. And I think, as physicians, our instinct can be to just start throwing information, at patients and start throwing content at people. But it's really important to recognize when the question is stemming from emotions rather than actually seeking information. And we can get to the information later, but it's really important to respond to the person's emotions first and create safety in the conversation. Because if there's no safe feeling of safety in the conversation, no amount of content you say will sink in. So
I completely agree.
What are some ways you think you can make this patient feel safe and feel validated?
I think for me, what has worked in the past is trying to dig a little bit deeper and see what's actually on the patient's mind. In this case, the patient is showing you this photo of her grandchild, and there's something deeper there. I think that simply, again, in my experience, discussing with the patient what their apprehensions are, what their fears are, what their hopes are, just having that honest discussion can sometimes really make a big difference in how the patient's demeanor is, and this idea of being so scared and wanting to know how long they have to live. I don't want to say it completely goes away, but they feel more okay with the prognosis of the disease because they simply have developed a relationship with the physician. And I think that that's huge.
Yeah. Emily, any thoughts?
Yeah, I feel similarly, and I agree that it's such a difficult situation, but it provides you an opportunity to clarify kind of what the patient's worried about, and as Ronak said, what their hopes are, but also to align your goals as a provider with their goals for treatment, but also their goals for family and for life, and to kind of reiterate that you most likely share the exact same goals as the patient to help them keep them as well as they can be for as long as they can be, so that they can maximize this time with family. And I think all of that goes to helps to add to the trust to the level of the patient to the physician and physician to the patient, and can have a more comfortable relationship to talk about more kind of data and treatment options kind of down the road after that initial trust is established.
Absolutely. I completely agree. It's clear both of you have already experienced situations like this and have some expertise in dealing with them. And it's really great to hear you speak about this. So I completely agree about the trust aspect. If the patient doesn't feel like they're in a safe situation where they can trust you as the provider, like I said earlier, no amount of content is going to stick, and no amount of content is actually what they're even looking for. And I think what you're both describing is a patient-centered approach to care, and a shared decision-making model where you're trying to tease out what's most important to the patient and what their values and wishes are, and also what their concerns are. So when someone's asking, how long do I have to live? Often I will just say something more specific, like what concerns you specifically. And that can start teasing out what this person's values are, so that you can then make the best possible decisions together about how to get them to reach those values. So then going a little bit ahead, so we talked about, this is an emotional question. You both, perfectly astutely described how you have to establish trust first and validate the person's emotion. Now, assuming you've done that, so the person feels safe, she's no longer crying, and now she kind of pushes again, and we're getting into the content portion of the conversation. So she asks, how long do I have to live? And this is a really, really difficult question. And it's also one of the most common questions that we get in hematology and oncology. And in terms of actually answering that question with content, I'm wondering if you guys have an approach to that.
I think you touched on it earlier when you mentioned that the patient was metastatic and the goal for the treatment would not be curative. It would be to stabilize the disease and, shrink it and prevent the progression. So I think that I would focus on that and kind of talk about that timeline and explain that it's, and kind of impossible to predict and to give an exact time.
I completely agree. I think that the severity of the disease, even without reaching for, these calculators and prediction models that are available, in itself would suggest that this is, we're talking possibly on the timeline of months here. And, I think it's in this case, as long as, like Emily said, we acknowledge that we don't have a crystal ball and we don't know exactly when that time is going to come. I think it's best based on what we know to give them a timeline of months. And, in the best case scenario, it extends to, in the order of years, but we have prepared the patient with the mindset that, the next few months are going to be difficult.
Yeah. So it sounds like, Ronak, you would lean towards giving more specific data, for example, months. Would you ever give a number?
I think that at this point in my career, I don't think that I've seen enough to feel comfortable giving a number. I think that by giving the order of months, again, I think it mentally prepares the patient for what's to come. And as we've both been describing, if really what we're hoping to achieve here is ensuring that our goals and the patient's goals are kind of moving in parallel, then by providing this timeline, I think it helps us also to continue the conversation as to what is most important and how are we going to proceed in the near future in terms of treatment, or whether that be focusing more on comfort, finding more time for her to hang out with her grandchild. These are all important things that I would want to uncover. And I feel like by giving somewhat of a more clear timeline, we're able to kind of address all of these things in a more timely fashion.
Right. I think the issue that we're hitting on is how specific is the right amount of specific. So, I think, as Emily said earlier, it is really important to say, is this metastatic or not? Is this curable or incurable? I mean, that's really important information to know. And it's surprising, actually, how easy it is to overlook that in the first visit, that the cancer is incurable. And there are ways to say that without taking away hope, but it is important information for someone to know that what the goals of the treatment are. The goals are not to make the cancer go away completely, but to shrink or stabilize the disease for as long as possible. I think another point that you hit on really well is acknowledging that, doctors are historically bad at prognosticating. And I've said that openly to patients. There are studies that have shown this, that we use phrases like we don't have a crystal ball, but all of that kind of hits on the fact that if you survey a bunch of doctors about the same situation, they'll give a lot of different predictions about how long someone has. And, a lot of people are wrong, and acknowledging that and being humble about it as you go further along in your careers is incredibly important. And then I think the third thing that you hit on really well was about giving a range, but not honing in on one particular number. So I think you're thinking about this exactly right. If you give one particular number, I think, someone will hold on to that. And of course, even a number, if you give someone a median, that's just the median. I mean, what does that really mean? There's a huge range of how someone will do. So one good tip that I've heard from palliative care physicians and I've used before is giving a best case, worst case, and most likely scenario. If you get the sense from someone that they're really pushing for more specifics in content, have you ever done that before with patients?
I have not personally been involved in a situation when that was used. I have commonly seen the palliative care folks give a range, as in, days to weeks versus weeks to months or months to years. So it's not as exact as you're saying, but I think sometimes that can also be a useful frame of reference.
And I think a lot of it is trying to get a sense of what kind of patient you're dealing with. And there are some people who really do want more granular information, and there are others who you'll get the sense, as you have already, that are okay with more generalizations, as long as you give some information that's just not so obscure that, so vague that they don't even know, whether it's curable or not.